I'm just struck with one of the points that you made, that our licensing and our particular guild model in the United States has precluded. And that is, I wrote something for a healthcare finance journal, and I got beat up for using the word substitution. And that really is what is being used. It's like, do we really need this, forgive me, OBGYN person, or could a midwife, or could someone else? And when I approached it from an economic model, which is what the journal wanted, and using the substitution model, we're structured in such a way in the United States that we can't use substitution very well because of our laws and structures of our educational, the way that we say only these people can practice this and only those people can practice that. And I think it's something we need to open up and really talk about, because it is an economic model that we have to explore. And then the last thing I would say, and someone may want to respond over there, is that I just recently did a consultation in New Jersey, which was all of the health profession schools were forced to consolidate.
Mm-hmm. Good. Other comments? Oh, I have a question for you. Okay, if you, and I don't have the statistic exactly correctly, but if you have a list of human organizations that have lasted more than 500 years, other than the Icelandic Parliament and the Roman Catholic Church, most of them are universities. Yet part of the global forces we're talking about are, you would suggest, a real transformation of the university environment. The consolidation that Patricia is talking about, is that, how will that work, do you think? Is that what will happen? That there'll be consolidation, that and that is something that, and health being a part of its university homes?
Yeah, I think the, let's say, one angle in response to your question is that globally, worldwide, the university systems are very, very rapidly being internationalized. So it's very clear, of course, that the United States was absolutely leading in science and academia over the last 50 years, but it's changing very rapidly. And it's changing in a way where academia is less individually on its own and has much closer relationships with industry. So the research communities in industry, and then in our field, you're talking essentially about, well, I mentioned Medtronic, for example, and GE, but also in the information world, Google is increasingly large in the health and medical field, Philips medical system, and then together with governments. And the best example of where many other countries will go, including China likely, is to look at Singapore. Singapore had a very explicit government policy under Tony Tan, who is now the president, actually, of Singapore, but was the previous Minister of Science and Technology, where he brought academia, so Nanyang Technical University and National University of Singapore, together with pharmaceutical industry and medical technology and physics, etc., and academia and the government. And they made some kind of a tripartite arrangement, and it was funded both from industry and academia and the government, and then you get an enormous growth. And now Singapore is, in Southeast Asia, absolutely leading in particular fields that they had prioritized, like oncology. Mm-hmm. So this is a kind of an internationalization of a kind of a public partnership with a heavy scientific academic element that likely will expand.
Yes.
Yeah.
I have other, Malcolm.
Yeah, I was particularly interested in your emphasis on the investment community, and largely because I hadn't thought of that. And so I wonder if you could expound a little bit on potential conduits to that industry. Would, for example, conduit be business school involvement, and because they're connected to the investment community, et cetera? But I'd just be interested in your thoughts of how to operationalize outreach to them.
Yeah, my sense is the the easiest access and entry to the investment world for in health and for education is the insurance world. So as I mentioned, the large internationally active insurers, and some of them are US, the other ones are generally Germany, France, and India now. The insurance world is very comfortable. That's what they do. They get so much money that on the other side of their economic model, they have to invest that money because it's not a direct transfer. So there's time in between. And it's not an overnight deposit and investment, but they have investment portfolios up to 40 years. The second one is that I mentioned with the pension funds. Now, the people in our world who deal with the big health insurance companies are your senior vice presidents finance in your academic center. So let's say Columbia Presbyterian Hospital has a senior vice president finance. Those are the colleagues that you want to engage with. They know. They're almost never medical professionals. They're always financial economists or economic or accountants, and they feel comfortable in that world. Then through that angle, and together maybe with the pension funds, you automatically end up with the BlackRocks and the Blackstones and the Adelphis and etc. Investment funds. And as I said, they are, if you look globally at the OECD structure, we have one positive element with us. That means that the health sectors will automatically become fairly large, right? The first law of health economics is that health expenditure is a positive fraction of income growth. So when and it applies all across the world, when a country gets $1,000 more in income per capita, people will start spending 1.3 proportionally more on healthcare than they did before. If you're poor, you have a headache, you don't go to the doctor. If you're rich, you have a headache, you go to the doctor. Right? It's very simple. So, and that trend will grow. So the health sector as such will become, at the national, from a GNP point of view, and economic growth point of view, will become larger anyway. Indonesia, yesterday I had a discussion with Sri Mulyani, the Minister of Finance from Indonesia is here. They will grow 10% this year. Just imagine, the fastest growing economy in the world. They have 46 medical schools that are not accredited. She, as the Minister of Finance, is aware of this. She says, we can't afford that. That's bad. That's bad for, she wants to see a healthy health sector in her country. So with these people, you have to engage. Yeah.
Good. A few more questions, and we'll have to go on to the next one.
Thank you. All of your remarks were stimulating and thought-provoking. And one of them that I'd like to ask you a bit more about is you mentioned about the perils of the professions controlling ourselves and the idea of opening up the market. How do you see that happening? Or
well, it will. Of course, it will. It won't happen overnight unless you have a revolution, right? And they still happen occasionally, but they are rare these days. So yeah. But I think there are trends from the outside that will urge you to do this. The mere fact that this group is discussing labor markets and entries and constraints and etc. is already an element of this, right? Now, the three big professions that traditionally in history had delegated power to control themselves by law were the medical profession, the legal profession, and the harbor pilots that bring in ships into harbors. Those three professions, the governments have no control over them. They rule themselves. But, as you can see with the legal profession, it's being diluted. There are lots of other practices now that are outside the traditional kind of guild-controlled orthodox rulers of law, so to say. The pilot profession has been broken up because of technology. My sense is that because we correctly talk about health professionals, that in line with many of the discussions here yesterday and today and previously from this group, you know, the health professions is increasingly no longer your standard cardiologist. And that's where the traditional power is. So the more you can push the model in a horizontal fashion and less in a vertical fashion, the more this kind of will be diluted and have the potential of opening up the market. Because it's really insidious if you have a labor market where the inflow is controlled. See? Yeah.
Kathleen?
Yeah, I think you also is really very stimulating remarks. My question is, or my concern is, I guess, as we're financing through the financial arena, health education, how do we protect in terms of the social determinants that whatever is financed being really profit motivated? You know, and I'm thinking of it, and correct me if I'm wrong, in two spheres. One would be for example, insurance companies as the financiers of health education on a certain level. And then what insurance companies do, which is provide coverage or payment. Could you see a way that we could assure somehow that social determinants, that is, things that are not so profitable to the larger umbrella of the financing system, would be protected so that we're assuring that we're creating environments where people who have less access and fewer resources are appropriately cared for? And we're training our educational professionals and others to address that. Is that a clear question?
Yeah, that was very clear. And I would have kind of three elements for consideration. One is, in response to your question, if and when you decide, either as an institution or a subgroup, to look for investments or engage with financial institutions, be selective. So look explicitly at those who have in the past shown to have an ethical heart somewhere in the company. And the best example of that is not exactly a health insurance system, but it's acting in a way like that, and it's very relevant for a group like this, is the Apollo healthcare system in India. Apollo started with ophthalmology, so eye hospitals in the south of India, where the entrepreneur, the physician entrepreneur that set up the system, he said, my intention is to treat the poor people of Tamil Nadu and Karnataka in a way that their eyesight will improve. But these poor people cannot pay. So I need to set up a system where I'm good enough that all the rich Indians who have eye problems also come to me. And he created an internal subsidy system. So the services and the eye surgery performed on the poor were funded by his high-income patients internally. It was exceptionally effective. And now Apollo healthcare systems in India has dozens of teaching hospitals, nursing schools, hospitals all over. It's a very big corporation. See, now engaging with corporations like Apollo on the ethical side and the social side, you're fine. Then the final element is from a university point of view, from an academic world point of view, you can encourage this. The University of Malaysia, for example, the vice president of the University of Malaysia made the social returns of the university, it wasn't the medical school, but from the university, she made it into an absolute priority. So her engagement of the University of Malaysia with communities outside Kuala Lumpur, across the countries, feedback, even including not only lawyers and history people or philosophy, no, economists and physicists, they had to go to villages and come back so there was a whole system that she designed with her colleagues, and they have a wonderful reputation. And of course, the government now recognizes that. All the banks, everybody knows about the university in Malaysia and Southeast Asia as to their social responsibility. So you can kind of identify protagonists and then go with them. Yeah.
So it always comes back to leadership and mission, as Malcolm has taught us.
So I think we're at time, but Pannenberg, I think your contributions were wonderful, and I'd like to thank you on behalf of everybody.